Keep still.
Okay.
See the kids cartoon.
Let's get ourselves focused there. Okay. Let's start right here. And Pollyanna, you're to start out.
Okay.
So what if I told you this was scalp?
Many follicles.
And are they big follicles or tiny little follicles?
Tiny little, not very deep.
Yeah, tiny little, not
It's
very
maybe
deep.
facial.
And so
It's the sparse lymphocyte infiltrate.
very sparse lymphocyte infiltrate. Another,
It's basal layer pigmentation.
there is basal layer pigmentation. My guess is that it's a darker skinned child. When you look at the dermis, the collagen bundles are very small, very red, fair number of fibroblasts. So this is probably kid skin, and a kid skin from a darker patient, and probably something that was cut out of scalp because it was a big hairless area.
Fat tissue is very up.
The fatty tissue is high,
Yes, it's high.
so which could be seen in things like lipedema and other things. What if I told you that this was a distinctly triangular hairless area in the scalp, parietal scalp? So triangular alopecia looks histologically somewhat like stable alopecia areata, where it no longer has the infiltrate, or like pattern alopecia with miniaturization of hair follicles. But it tends to be congenital, long-standing, and the hairs are vellus forever, basically. And in this case, this probably was taken out as a surgery, perhaps thinking that it was a early nevus sebaceous, or knowing that it was triangular alopecia. But it gave us a nice big piece to look at. Okay. Very good. That was probably tough because it needs a lot of clinical correlation.
Yes.
Okay. Shufan, what do you think?
Soft tissue.
Yep, soft tissue neoplasm. And the nuclei tend to be very wavy.
Huge.
Yeah, so it looks like neurofibroma, sort of diffuse with wavy nuclei, and then it goes deeply into the fat, trapping lipocytes. You have single file rows of lipocytes, almost as you would get with a DFSP. So what pattern neurofibroma is that grows into the fat like a DFSP? Yep, I'm hearing a diffuse neurofibroma, which is always associated with von Recklinghausen's, essentially. So diffuse neurofibroma looks a lot like myxoid DFSP, but stains neural, just like an NF, and is very, very strongly associated with loss of heterozygosity in neurofibromatosis. Pilomatricoma, your response was a little slow, but good. So we have lots of shadow cells, right? Lots of shadow or ghost cells, and basaloid tumors, and the two others are saying, why couldn't I have gotten the pilomatrixoma? Theirs were a little bit harder, but you do get to hit the easy button for that.
That was easy.
Okay, so how about this?
That looks like a pyogenic granuloma.
Looks kind of like a pyogenic granuloma in that it's distinctly lobular. It's a little different from a pyogenic granuloma in that this is full of eosinophils. The endothelial cells, rather than being fairly normal as they would be in pyogenic granuloma, are kind of large and histiocytoid or epithelioid in appearance. So it would be a lobular proliferation of histiocytoid endothelial cells with lots of eos and some lymphoid hyperplasia.
Like ALHE.
Like ALHE, and this is the end of that spectrum that's histiocytoid hemangioma. So histiocytoid hemangioma is a variant of ALHE that is more vessel, less lymph.
A little like KS with
A little similar to Kaposi sarcoma, not as spindled as KS would tend to be in the nodular phase. And you could always do an HHV8 to confirm if there were a question. So good point.
Somewhat of a blue nodule.
Somewhat of a blue nodule.
A little bit
Are the cells round or are they spindled?
spindled.
Spindled. So it's a spindle cell neoplasm. Not quite slammed all the way against the epidermis, but certainly a spindle cell neoplasm forming a nodule.
So, I mean, can you do the slam differential if it's that close?
You sure could, especially since there's atypia and mitoses in this. In fact, quite a few mitotic figures. So your SLAM differential would include,
SCC, glioma, SARC, AFX, and melanoma.
and this one stained as a melanoma. And the reason it's not slammed up against the epidermis is it's a met, right? Which is why it's kind of just a ball.
how about the solitary fibrous tumor?
So SFT, solitary fibrous tumor, would tend to be deeper. This is dermally based and very superficial. SFT tends to be based in the deeper soft tissues, doesn't break into fascicles. This has almost a trabecular pattern.
Okay.
SFT tends to be solid with a so-called patternless pattern, and then often staghorn vessels like hemangioparasitoma embedded in it. So good question.
Well, lots of pigment at the DJ. We have a lot of, it looks like atypical nests. Yeah, I mean, melanoma is definitely up there.
Yeah, so you have confluence at the junction, irregular nesting, effacement of the reedy pattern, pagetoid scatter, a fibrotic stroma that pushes the rest down, and within that are large nodules of melanocytes, and those are larger than the largest one at the DE junction, so there's a vertical growth phase, right? Is this melanoma or is that pre-existing nevus?
I think pre-existing nevus can have those like fat-like cells or
So it appears to disperse.
pre-existing.
It has nice nuclear pseudoinclusions, and in this stain, the elastic fibers are picking up a lot of eosin, so you can see it retains elastic. All of that helps tell you that that's just nevus, so you don't want to measure that for your depth. right? And elastic is often the best way. Most melanomas push elastic out of the way, whereas the elastic is preserved throughout the nevus, so it's a good way of telling what's what when you're getting your depth.
Looks like a squamous proliferation.
So you're saying it's a DST, right?
Right. A lot of squamous eddies kind of falling apart.
Just
Could just be really
Yeah,
irritated
squamous thing,
seb. There's like an acantholytic squame.
Yeah, so you pointed out lots and lots of squamous eddies. The older keratin before it became angry is lamellar shredded wheat.
Yeah. Favoring seb.
The bottom has a string sign,
Yeah.
so irritated seb. Kind of a wild irritated seb.
It's like a dermal proliferation here.
So large or small?
Large.
Large. And then tell me about the overlying epidermis.
Acanthosis.
Acanthotic. Tell me
So,
3 larger tumors that don't efface but rather have acanthosis.
granular cell, DF, and Spitz.
Granular cell DF and Spitz. Is this a GCT?
No,
Is it a Spitz?
No.
What's left?
DF.
Yep. So at scan, that's dermatofibroma because it's a fairly large tumor that produces acanthosis rather than effacement. And then, you can look higher and see that it has a curlicue pattern and multinucleate giant cells and histiocytic cells and stains like a DF. But the overlying acanthosis is a major clue.
Would you stain that one? Like first
Probably not.
Yeah.
Probably just call it an H&E.
So I'm not sure if that's a little blister, perhaps, with this processing.
Probably artifactual,
Okay,
given the way it looks.
never mind.
there.
So there's an infiltrate of kind of lighter colored cells, a little bit of epidermotropism,
So there's definitely some epidermotropism. Tell me about the papillary dermis.
a little bit fibrotic.
A little bit fibrotic with limbs lined up between that ropey collagen.
MFE.
A little MFE, which is exactly what it is. So epidermotropism, lymph in every hole, wiry papillodermal collagen, limbs lined up between that papillodermal collagen.
Noduloma. Anguloma.
Yep. So a marble-like red nodule. And in fact, let's go down to 50% so you can architecture.
That was easy.
So a marble-like red nodule, and you can see the little glycogen vacuoles in there of smooth muscle. The only thing that looks like this is an angioliomyoma.
We're releasing our epidermis here. There's some islands. I'm not sure there's a collagen fibers within this proliferation.
So there's sort of keloidal collagen within it, and little islands or theques of cells, all uniform or pleomorphic.
Pretty pleomorphic.
Mitosis present.
Yeah, some just present. Maybe like spines. I'm not sure.
Yeah, it certainly could be squamous cell carcinoma. You'd probably want to know what the patient had before,
Some of
and
this kind of looks melanoma.
yeah, and this is in fact melanoma. So another metastatic melanoma.
A well circumscribed little bump.
So well circumscribed little bump. clefts between fascicles. So what are you thinking? What gives you a well circumscribed little bump?
Neurofibroma.
The clefts between the fascicles help too, and also if you saw the whole thing, it would be like this, sort of vertically oriented, probably on facial skin.
Second angiofibroma.
You're in the right ballpark. So with the clefting, PEN, palisaded encapsulated neuroma, these tend to have the really pronounced clefts between the fascicles. And these are tough cases. You don't know what chapter the case is coming from, but this is the perfect opportunity. Make every mistake you're ever going to make in this room so you don't make it in another room.
In real life,
Like-
they're going to have a chapter number on the slide, right?
Oh, in real life, yes. In real life and on exams. In fact, the patient comes in with the chapter tattooed on their forehead. Yes.
It's great help.
It is a tremendous help, yes. They do that at the registration desk. Okay. Let's keep on going. So we see lots of bundles of smooth muscle, and then in the center, sebaceous glands and a duct down below.
Smooth muscle hematoma.
So it looks kind of like smooth muscle hamartoma on either side of hair follicle with very prominent sebaceous ducts or sebaceous glands, and then an apocrine kind of duct. Nevus sebaceous would tend to be broader, and this little thing with all the muscle around it is probably accessory nipple,
Okay.
right? So accessory nipple, where you have the smooth muscle, the sebaceous in the center, and the duct running up the middle. Very good. So your stratum corneum, normal basket weave. Your epidermis, happy or unhappy? Unhappy, very unhappy, right? So, and judging by the corneum, I would say very acutely unhappy. Full thickness unhappy, very acutely. So what are you thinking? And death far out of proportion to lymphocytes. So I think I heard it. EMTEN differential. So erythema multiforme, toxic epidermal necrolysis. Everyone today needs to review the images of a patient who came in over the weekend, who was a young man diagnosed with lymphoma recently and now has horrible crusting around his eyes, his lips, and widespread erosion on skin. He has suprabasilar acantholysis as well as eosinophils throughout the epidermis, forming bullae and clefts, and it's almost certainly PNP.
We got his panel back. He was the one I was talking to you about. It's
Oh.
negative.
No, it's a different patient.
Oh,
Yeah.
It's a
No,
new
no, this one came in this
Yeah,
weekend.
different.
Oh,
Just
that one
came
came
in-
in Friday.
Yeah.
Okay.
Yeah, so we don't have
Another one.
anything.
That's
And so, very high risk to the patient for death, especially with bronchiolitis obliterans,
Yeah.
acute tubular necrosis. So, he came in actually with a question of Stevens-Johnson TEN. Doesn't look like that, and cyclosporin certainly would not be an option. Appears to have gram-negative sepsis as well as
Oh.
acute kidney failure. So corticosteroid, rituximab, IVIG are things that may be safe in that setting and potentially life-saving for the patient. But good to know all of the, we can't share any HIPAA information, but like grand rounds we can discuss on de-identified patient characteristics to work through a tough scenario. Okay. So what do you see?
Scar-like area.
Scar, exactly. So you got scar, and you can make out the myofibroblasts that are very wavy with the equally wavy collagen, kind of corkscrew pattern, horizontally oriented, vessels vertically oriented in a chronic scar. And then in this particular patient, when you look at the cells, you can make out that a lot of the erythrocytes, instead of being round, are kind of in the shape of a scythe or sickle. So this is chronic ulcer in a sickler. So you have scar, and you can make out the sickle cells in the sickled erythrocytes in the blood channels. Okay. Obviously done as an alopecia biopsy, right? So you have your horizontal and you have your vertical. Let's focus on the vertical.
Got kind of like vertical streaking of lymphocytes.
So what's your diagnosis? Lupus, and you are correct. So you have hyperkeratosis, you have interface dermatitis, you have vertically oriented column of lymphs in the mid dermis, which is probably the easiest way to get to lupus. And then you have patchy perivascular lymphoid infiltrate. You have naked hair fiber telling you it's a scarring alopecia, but this vertical column of lymphs in mid dermis is pretty good for lupus.
Little papule.
How happy is your epidermis?
It's not too happy. It looks like the
Yeah.
perineum's pretty acute.
Moderate. It looks kind of acute and it looks moderately unhappy, but not really TEN unhappy, right? And they took a specimen that went down pretty far. And what do you see down pretty far?
Looks like calcium, like calciphylaxis.
Yeah, exactly. So every last little capillary looks calcified, and then you have thrombi in the vessels. Those are the two features you have in calciphylaxis. So the way you can address calciphylaxis is to dissolve that calcium with something like thiosulfate, or use tissue plasminogen activator to dissolve those clots, which are causing the infarction, which is what's causing the still just moderate unhappiness above that's going to become much more unhappy, right? Because this biopsy was probably taken towards the edge of the necrotic, of the rock-hard retiform necrosis.
Looks like we have some papillary dermal degeneration, or edema, and then some nodular infiltrates around vessels, some sponge.
Yeah, so definitely sponge to the point of vesiculation, right? So if you had to put it in a broad category, where would you put it?
Trying to look for any EOs for a happy differential. I don't really see any.
Yep, don't see EOs, but so just a spongiotic dermatitis differential, and then given the ropey collagen in the papillary dermis, is this more like an acute or a chronic spongiotic
It's more
dermatitis?
chronic with that.
So
ropey
more
collagen.
chronic spongiotic dermis because of that ropey collagen. And this is something on the face and V of the neck and forearms. So kind of, I'm trying to lead you to a photo distribution
Yeah.
for it.
Right.
And this was, it was, so PMLE, papillobesicular PMLE is spongiotic. Plaque-like PMLE is the one with the coat sleeve infiltrates around vessels. This one was a photocontact, which tends to be towards things that absorb light, like sunscreens especially, which account for the majority of photocontact.
Looks like something that probably doesn't belong in the skin.
Something that probably doesn't belong in the skin.
These clear cells,
Clear cells, lots of blood.
clear cell RCC.
Yeah, so renal would probably be your first stop. Kind of elongated nests or tubules, clear cell, very bloody. Renal cell carcinoma.
Here, the basaloid perforation in the dermis. I could tell if I was looking at cylindroma.
I'm sorry, I didn't hear. What did you say?
Cylindroma?
Cylindroma, very good. So you have basaloid proliferation in that they are nuclei with no red cytoplasm, but the nuclei are distinctly darker to the outside, paler gray to the inside, surrounded by a thick basement membrane zone that's red, and they fit together like jigsaw puzzles. So that cylindroma, when they are more inflamed with lymphocytes and forming big balls, that's a spiradenoma. The two often go together and are closely related.
It's another ball in the dermis.
Okay.
Doesn't really have red ducts. It does have those red blood cells.
Now the red blood cells in apparent vessels, or are they just in there between the
They're
spindle
just
cells?
In there between the spindle cells.
What are you thinking?
Is it like chaos or something like that?
And you get credit for Jeopardy for phrasing it in the form of a question, so very good. So spindle cells with erythrocytes between them, not an apparent vessel, goes with nodular chaos. Early patch KS is staghorn, lymphatic-looking vessels, often with plasma cells. Patch KS is busy around every pre-existing structure in the dermis with new vessel formation, and tumor nodular KS, spindle cells with erythrocytes between them. Very good. Epidermolytic acanthoma, very good. Just keep that easy button parked there. So sort of Ka-like crateriform often, but with EHK, epidermolytic hyperkeratosis, is the major change. Compact keratin layer, and the vast majority of these are in the genital region, with the majority being in the scrotum of older males who only want to know that it's not condyloma, so that they can tell at home, they can say that it is not condyloma, and then it's no longer an issue for them.
The whole perikeratosis.
Yep. And a real spine, right?
Like kind of cutaneous worm looking.
Yeah. And on what part of the body do you think?
Maybe 8.
Maybe volar?
Yeah, volar skin.
So not a real AK site, but what would be associated with a duct, and then above it have an almost porokeratosis-like column of perikeratosis, and give you a spine like keratoderma. So what's called music box spine keratoderma, which is also Porokeratotic Echinocioduct nevus. Looks like
Like a music box.
like music box spines all over your palm.
Is there a certain name for that kind of like keratinization, that like dense, like besides it's not like cornoid lamella? I mean,
It's kind of cornoid lamella-like. It's just compact hyperkeratosis. I mean, there may be some other name, but not that I know. Okay, we need a poetic description of this.
It's like a sea of snot.
So that's as poetic as it gets. Pure poetry. Blue islands floating in a sea of snot. Mucinous carcinoma, and that can be primary or it can be metastatic. The metastatic ones can be from breast, in which case they stain very much like the ones from skin because they're both of modified apocrine type differentiation. And then the gut ones, especially distal gut, tend to be CK20, CDX2 positive, so they stain like gut carcinoma, which can help differentiate those.
Dermal speed.
Dermal spits, well done. Hit that easy button there.
Thank you.
That was easy.
So you have linear theques or fascicles of cells with very prominent, they're large epithelioid, they have prominent nucleoli. There is no overlying acanthosis, hyperkeratosis, pseudoepitheliomatous hyperplasia, because it's almost purely dermal, right? And you don't tend to get that in a dermal spitz. So dermal spitz looks spindle and epithelioid, just like the dermal component of any other spitz, but it lacks the lacks the overlying pseudoepitheliomatous hyperplasia. Everything looks fairly normal until you get into some necrosis, and then this structure here which has a concentric ring of this kind of tissue pushed apart by inflammatory cells. So the original structure was probably round with this wreath of smooth muscle that's now pushed apart with acute and chronic inflammation. So, yeah, I think I heard polyarteritis nodosa, PAN, is most likely. So concentric ring, like a wreath of smooth muscle, inflammatory cells pushing apart those layers of smooth muscle. So it's an artery that's having a very bad day being attacked by acute and chronic inflammation, which usually goes with polyarteritis nodosa. We have no surface epidermis. We have deeper tissue.
Fats, mucinous, spindle-like substance. So could be a spindle cell lipoma, but it looks a little bigger.
So could be spindle cell lipoma. Do you see any ropey collagen?
No.
Hard to make a diagnosis of spindle cell lipoma in the absence of ropey collagen, right?
Yeah, there are like single file areas of fat. I mean, it's like
There are definitely single file rows of lipocytes, so you characteristically that goes with what?
DFSP.
So this could be myxoid DFSP. What else can look just like myxoid DFSP? What stains S100 positive?
repeat, I guess, what we had earlier.
Yep.
Yeah.
Diffuse neurofibroma, right? So your differential is diffuse neurofibroma versus myxoid DFSP. The Meissner-like corpuscles favor neural, right? And this indeed stained neural and was from a known von Recklinghausen's patient.
So got some like kind of vertically oriented vessels and void aggregates around the period. That's a pretty vascular.
So what are these
vessels,
things?
I think those are vessels.
Do you-
No, they look like giant cells.
Yeah, they look like giant cells. So these are all granulomas,
Okay.
right? So the first stop is these are granulomas. Are they naked or do they have a heavy lymphoid infiltrate or are they partially clothed?
Partially closed.
These are kind of partially closed, right? They're undecided.
Right.
So give me a differential for naked granulomas.
Like sarcoid, cutaneous Crohn's.
And this was cutaneous Crohn's. So this is from the vulva of a little girl, and this is cutaneous Crohn's, right? So unilateral vulvar swelling, little girl or teenager is usually Crohn's, right? Is usually IBD. So cutaneous Crohn's, sarcoid, what else?
Can some of like your TB or kind of those things?
More like zirconium, beryllium,
Okay.
tattoo granuloma. TB tends to be on the dressed side where there's a significant lymphoid infiltrate around it. So the infectious things tend to have more of a lymphoid infiltrate, whereas the non-infectious granulomas tend to be more in the naked arena.
So it looks like part of the corneum's very compact.
So part of the corneum's a little compact. Do you see any other pathology here? Not really. So where do you want to look?
And the corneum.
In the corneum! Well done. So let's look in the corneum since that looked a little funky, right? So we're going to look in the corneum and see. And you can kind of make out in that compact corneum, can you make out sort of vertically oriented gray amphiphilic stuff there that's not hollow like fungus?
Right. So is it like bacteria?
Yeah. So what would be vertically oriented bacteria?
Like a corine?
Like Corynebacteria? Like what helpful instrument in clinic do you want to pull out to make this diagnosis?
The Woods lamp?
The Woods lamp, because this is erythrasma. Well done. You need an easy button over there.
Sarah.
Here you go.
That was easy.
So we have
So is this acute or chronic process?
chronic.
Pretty chronic. You have papillodermal fibrosis, you have a lot of acanthosis, hyperkeratosis, so this has been going on a while. So what's been going on a while?
I think I can appreciate some nodular angioplasia.
There's nodular angioplasia. What else is there?
Or, no, oops. Big old scabies.
There's scabies.
And this
Right.
part.
So first off, anytime there are holes in the corneum, if someone hands you a box, what's your question? What's in the box? Someone hands you a hole in the stratum corneum, what's your question?
Yeah.
Yeah, exactly. So holes in the stratum corneum aren't normal, so it's a tunnel. And then you see mama right there. Right. So this is obviously a very chronic, itchy scabies. Not diagnosed until this biopsy. How are we doing time-wise? About 15.
We got bone.
You got bone. And then Why did this bone come out?
Oh, that gout.
That's gout. Correct. So that is a gouty tophus in, probably part of a toe that came out.
So yeah, round two cells. Like
Okay, so you have these very round blue cells, and then they turn into that.
Oh, more like a polymetric.
Exactly. So this is a great pilomatricoma, right? Because it's almost all basal cells, and you got that little bit of ghost cell, and there's no question what it is. But that's one that would, yeah, not tricky though, right? Straightforward diagnostic. Thank you very much.
Pretty straightforward diagnostic.
It's a big punch. It's kind of almost layered, square, like a
Almost
cake.
like layered and squared,
A
like
cake.
a cake.
Or LDS. Or NLD.
NLD.
You
Yes.
knew it.
That's what I meant.
Something on the leg with 3 letters, right? Okay, so NLD, square punch, layered granuloma with devitalized collagen. Very good. Well done from Stan.
Something's going on with the
Shave biopsy, and what did they shave the top of?
glandular stem.
A GCT. And so you look for the giant lysosomal granules, which are present,
That was
telling you
easy.
it's probably going to stay S100 positive as a neural GCT.
For
So Shirley is getting towards the end of her fellowship, which is why she knows all. For anyone who has missed any slide, you will have to complete your training. This may come as a shock. But
Nevoid cells there.
kind of nevoid cells in nests.
Yeah, a little. And the nests aren't totally uniform, but it's in a small papule. I don't see a lot of like
How old do you think the patient is, judging by the collagen?
young.
Young. So this young proliferation that ends in a nest, matures, disperses,
Right, I mean, I think it's benign.
Has-
It's got kind of these vertical oriented nests.
vertically oriented nests of large spindle cells,
Like a
spits.
spitz.
And that, anytime you see a spitz, your first question is this young skin? Is this old skin? Right? Because you can often tell just by looking at the surrounding skin.
Something bad.
Yeah. Do you see any atypia? So lots of 20-pound nuclei and spindled cells. So give me a differential.
It's kind of slammed up against there's going to be a squame,
Yeah.
leiomyosarcoma, AFX, or melanoma.
And this stains with nothing but CD10.
So an AFX.
So it's probably AFX. Correct.
Solar lamp.
Yeah, solar lentigo, or if it forms horn cyst
bone.
reticulated seb, or if it goes down all the follicles, Dallingdagos. But in this case, look, what we have just looks like solar lentigo. It may be anastomosis enough that you might want to think of reticulated seb, but benign in either case. Bless you. spindle cells, erythrocytes in no apparent vessel. So I'm hearing it from several.
Okay, yes.
Kaposi is properly pronounced Kopshi, although his name was Morris Cohn. He just came from the town of Kopshi where the Kopshi River was.
We'll not rest until it gets its proper recognition.
Why, yes.
Subepidermal bulla.
So subepidermal bulla filled with
EOs.
EOs, and so your diagnosis, or
Bled, BP, linear IgA, EPA, bolus, lupus, DH.
so all of those are good. Also remember bullous scabies can look just like BP. Who gets BP? Old people in nursing homes. Who gets bullous scabies? Old people in nursing homes. So keep that in your differential. This particular one was EBA. Remember, 10 to 20% of what looks like classic BP doesn't tend to respond well to treatment. Those tend to be the EBAs, and they're the ones that more likely have other systemic associations, including malignancy.
So, got some perivascular nexal with the sites.
Perivascular periadnexal, some lymphs in the eccrine coil,
Yeah.
superficial and deep,
Let's think of lupus.
lupus, and why is there so much space between the collagen bundles?
There's a lot of mucin.
There's mucin in there, so you are correct. Lupus. You are the queen of lupus this morning, so you get to hit the easy button.
Thanks, Katie.
That was easy.
So it looks like there's like a little bit of fibrosis in the papillary dermis.
I'd say more normal if we went higher, because it's not really ropey,
Okay.
right? So it may just be site where it looks a little, more uniform. But what are
So
these
there's
brown things?
A lot of pigment. It's horizontal.
Horizontally oriented dendritic melanocytes with no alteration in the collagen, and it's in the upper third of the dermis.
So like nevus of Oda or
Nevus of Ota or Ito, and this particular one was Ito's nevus. Okay. Tell me about your epidermis.
Looks pretty unhappy.
Fully unhappy or partially unhappy?
Partially unhappy.
Partially unhappy. Now let's look down. And what's going on down below?
The fat looks pretty necrotic. Oh, and that vessel too.
So lots of thrombosis, right?
Yeah.
So give me a differential.
I guess it's a pretty large vessel, so you don't really think of calciphylaxis.
Which is actually what this turned out to be,
Okay.
but with larger vessel thrombosis, what other things are thrombotic disorders that could lead to the same kind of necrosis?
I guess antiphospholipid or protein CS.
Yeah,
or-
protein C, protein S,
Yeah.
factor V Leiden, antithrombin 3, prothrombin mutation, your whole coagulopathy disorder. If it were sepsis, you would tend to have neutrophilic debris. They'd be dirtier with more inflammation in the vessel. We got about 5 minutes.
It's pigment incontinence. The
Pigment incontinence suggesting,
interface process.
yeah, probably an old interface process. In fact, do you have a basal layer or is everything squamatized here?
Squamatized.
And your follicle itself,
It's plugged.
and
Hypergranulosis.
a little glassy.
Glasses.
What kind of things can do that?
Could be could have been a regressed KA or lupus, hypertrophic lupus.
So, and which one of those is more likely to give you a burnt out interface dermatitis?
lupus.
So hypertrophic lupus is high on your differential. The collagen is also very sclerotic here, though, right? So I agree, that follicle, that glassy
Oxidative.
follicle really makes you think hypertrophic lupus.
Like a sclerosis, kind of burnt out. Morphia overlap. Or
Morphia overlap, all of those things are good. This is a patient post bone marrow transplant. Sclerodermoid GVH, where you have both the sclerodermoid and the late interface of GVH. Everything's fine and dandy until you come to that. What kind of vessel is that?
The larger vessel.
With that concentric, continuous wreath of muscle?
PAN.
Polyarteritis nodosa. That's an artery, and that's PAN. Very good.
A lot of granulomas in there.
And those granulomas are
Non-naked.
non-naked, and anything else about them?
They're kind of stellate almost.
Yeah, like palisaded.
Right, so
Palisaded around what kind of stuff in the
necrotic
center?
stuff like NXG perhaps. Or is that collagen?
That's a lot of elastic
Elastics.
being engulfed.
Is that like elastophagocytosis?
So it is elastophagocytosis.
Granuloma?
So,
O'Brien?
so it could be an O'Brien granuloma annular elastolytic, which many people regard as just GA on sun-damaged skin, but it's certainly a type of GA on sun-damaged skin that eats up elastic tissue.
The epidermis not unhappy, is unhappy. I see
First.
some mucinous cell
So,
or confluent and acidic proliferation
yep,
in the
so you'd call that,
conjunctiva.
you are correct. So this
MIS.
is MIS affecting both skin and conjunctiva of lid. Well done.
Nodular lymphoid aggregates. Seems kind of vertically ranging.
So what do you
about
think?
lupus.
You are correct.
Reach level.
A nodule, probably a deep nodule. You have extravasated erythrocytes, what look sort of like osteoclasts, like giant cells, lots of microvesiculation, lots and lots of microvesiculation in the stroma, and some pyramid-shaped with dendrites, fibroblasts, similar to what would be seen in tissue culture.
Fibromatosis.
So is that a description of fibromatosis or of nodfash?
No, not sure.
Nodular fasciitis. Very good. And let's do one last. Accessory digit, a nidget. It's got the nerve, bungle, and acral skin features. Very good. So for anyone who missed a slide, you will be finishing your training, which is as it should be. Okay, well done.
Shirley, we have your certificate waiting in the